Hi, everyone. Welcome. We're going to be letting people in as we get started here. If everybody could put themselves on mute, I'd greatly appreciate it as we get started. And I'm going to go ahead and pull up our agenda. And so welcome to the HOPE meeting, our second meeting, which is education focused. I'm so excited to have all of you join us. Hey, so welcome everybody here to the HOPE program. My name is Jen Jones. I'm the founder of Sober Livers and the HOPE program. And we're going to do a couple of brief introductions here in a little bit. But first, I wanted to give you guys a few Zoom instructions. If you have a question or you'd like to talk during this meeting, please use your raise hand button. The raise hand button is located at the bottom with your emojis, with your reactions. If somebody has trouble finding that button, please send a message to the chat to Nancy, and she will be able to guide you through that process. And if you do have any reactions that you'd like to share, we welcome reactions. We love them because we think that adds to the fun of our meetings. So if you want to go ahead and do those as well, whenever you hear anything you like, we'd love to hear that from you too. And we also have chat available, and we'll go through a little bit of chat instructions here in just one moment. But first, I was going to go ahead and introduce myself. Again, my name is Jen Jones, founder of Sober Livers and the HOPE program. I recovered from alcohol. Well, I'm in recovery from alcohol use disorder, and I was diagnosed with severe alcohol-induced hepatitis in 2018 and decompensated cirrhosis. But I was able to maintain my liver even with a 30% shot of living. And that's what has brought me here today. It's now my mission in life to help other people who are suffering with a complex condition of having both alcohol use disorder and also alcohol-associated liver disease. And I put in another message to you that our bios are available on the website under Meet the Team. So I'm not going to tell you much more about myself because we've got a lot ahead of us today. So I'm going to go ahead and introduce Beth Lehman, who is our Principal Strategic Advisor, coming to us from Alaska today. Take it over, Beth.
Hi, everybody. It's nice to see you guys. I am in Alaska this week, so it is still sunny and bright out. But I guess I should say it's sunny and bright out all the time. I had my first day of 24-hour sunlight yesterday, which was odd. But like Jen said, my name is Beth, and I had alcohol-related cirrhosis back in 2019 and went straight from a primary care physician straight up to a transplant hepatologist and was told I needed a transplant. During transplant evaluation, they found liver cancer, and I already had 5 tumors, so it was pretty advanced and had to go get cancer treatments after that. And after many, many little fires and coming back on and off the list, I received my transplant in April of 2021. And since then, I have been working to try and educate folks. I'm very passionate about early detection of liver cancer and also just helping everyone here and providing a support group for those of us that do have the issues with alcohol, because we hope that this is a safe place for you guys to talk as well as us to talk as well. Looking forward to sharing.
Thanks so much, Beth. And I wanted to introduce 2 other folks to you. I can't see everybody right now. Is Aaron on yet, Beth?
He is not that I have seen.
Okay.
No.
Okay. All right. Okay. Aaron will pop on later and we'll go ahead and introduce him later on in our program. But I wanted to introduce Nancy to you. She's our chat facilitator, and a couple of notes about the chat function. You will see that the only people that you can chat to right now are all of our co-hosts. We ask to keep things simple because we are all going to be kind of busy doing other things as this meeting goes along, that you just chat with everyone unless it's an extremely private question that you have. And then please share that with Nancy, our chat facilitator, and she will make sure that she gets the question answered, or if it's a medical question, she will make sure that we jot it down so that we can ask the question to our Whole Health Advisory Council. And our Whole Health Advisory Council is made up of both physical and mental health providers, and you'll get to meet one of those today, who is Dr. Bob Weinreb. And so go ahead, Nancy, take it away.
I had to unmute myself. I'm Nancy, everyone. I'm 5 years post-liver transplant. I drank for 34 years, and being diagnosed with cirrhosis was a huge wake-up call. Now I try my best to advocate for people who have liver disease, people who are waiting for transplants. I mentor people in several Facebook groups. I've advocated on the legislative level for the Liver Act being passed and for funding for more testing and screening on a regular. And I volunteer for several organizations, and I'm more than happy to help in any way I can. And I'm glad to be here. I'm glad to wake up every day. So, and it's good to see all of y'all. So many people here today.
Thanks, Nancy. And Nancy is just very knowledgeable. So please ask the question. And like I said, if it's medical in nature, she probably will not answer you. But if it's something that's simple, like how to calculate your MELD score or other things like that, I'm sure she can help you out with those things. Okay, well, now that we have that done, I want to go through our HOPE agreements. And I also sent in a message to you about the HOPE agreements and where you can find them. So I'm going to go through these fairly quickly so we can give room for our speaker. But here are group guidelines. Participation is encouraged, but please inform us in chat if you prefer to listen only. And during feedback, please share your opinions with empathy and compassion using I statements. For example, I had an MRI instead of an ultrasound because I had iron overload. Medical advice. Feedback is not medical advice. Please consult your health provider before trying anything discussed here. Inform us if you are a medical provider so that we can make sure everybody in the group is okay with you staying. Confidentiality. Ensure you are in a private space. Please use headphones if needed. Do not share details about this group with anybody else outside of the meeting. I know we get some juicy details in here, but keep it to yourself. Cameras. Turning your camera on will help us foster connection and community. So please show us those beautiful faces of yours. And then anonymity. If you wish to remain anonymous, use your first name as your screen name and keep your camera off, but please inform our facilitator privately in the chat. And please share what stage or transplant status you were in. And I wanted to mention something right now because I forgot to mention it earlier. Please introduce yourselves in the chat. If you could please introduce yourself by telling us where you're from. We'd love to know where everybody's coming from. And then what disease state you are in. And then also give us a feeling of how you're feeling today, whether you're stressed or whether you're joyful or whether you're in bliss. We'd love to hear it. And those are dogs in the background, if you can hear them. Abstinence. Well, abstinence is not required to attend. Please join our meeting sober. And if under the influence, do not participate verbally in chat or except to contact a facilitator for support. Provide your contact info for treatment so you can get treatment resources if needed. Nancy can help you out with that. So please let us know if you're in need of help because that's why we're here. Politics, Sober Livers is nonpartisan. Our focus is on our shared experiences with AUD, that's alcohol use disorder, liver diseases, transplant, and other related health issues only. And secularity. Sober Livers is primarily secular, but we do welcome discussions on spirituality or religion as part of your recovery, following our feedback guidelines that I talked about earlier. And everyone, we are here to learn from each other, offering compassion, empathy, and kindness. So please take what resonates with you and leave the rest. I'd like to introduce, before we introduce our speaker today, we do have an observer with us. His name is Dr. Ashwani Singhal, and he is the chair of the American Gastro Association Council in the liver section. He's also the professor of medicine, University of Louisville School of Medicine. He's the director of clinical trials and hepatology at UOFL Clinical Trial Unit and Physician University of Louisville Physicians Group, hepatologist, University of Louisville Health and Jewish Hospital, transplant hepatologist, Traeger Transplant Center. So we welcome him here today, and he will be part of our question and answers. So if you do have questions that maybe a hepatologist can answer, or maybe this is a great time to realize the synergies and that is involved in interdisciplinary care. So welcome, Dr. Singal. And with that said, I'm going to pass it over to Beth so that she can introduce our guest speaker for the night, Dr. Bob Weinreb. Thanks, Beth. Oh, you're on mute, Beth.
Fantastic. What a way to start there, right, Bob? I wanted to introduce Dr. Weinreb. Dr. Weinreb came to Philadelphia in 1991 after completing his residency in adult psychiatry at St. Vincent's Hospital of New York Medical College in Greenwich Village. He then completed a Department of Veterans Affairs Fellowship in Addiction Medicine from the Penn VA Center for the Study of Addictions in 93. His responsibilities including having served as medical director of the Treatment Research Center for 7 years. He has served on the Penn Institutional Review Board for Human Studies, the Penn Medical School Student Standards Committee, say that 3 times fast, and the Standing Conflict of Interest Committee of the University of Pennsylvania. From his work as the consultant psychiatrist for the liver transplant team of the hospital of the University of Pennsylvania, which he implemented in 1995, Dr. Weinreb became an NIH and VAMC grant-funded investigator, focusing his interest on the treatment of psychiatric and addictive disorders in solid organ transplant patients. His primary clinical and research interests focus on liver transplantation for people with alcohol use disorders. He has been the recipient of a number of research and teaching awards, including the Lindback Award for Distinguished Teaching from the University of Pennsylvania. He was director of consultation liaison psychiatry in the Psychiatric Emergency Evaluation Center at the Hospital of the University of Pennsylvania from 2006 to 16, and is currently the chief psychiatric consultant at the Hospital of the University of Pennsylvania. Perelman School of Medicine. Dr. Weinreb founded and directs the only outpatient psychiatric clinic for transplant patients that treats their patients longitudinally. He thoroughly enjoys teaching and mentoring undergraduates, medical students, dental students, advanced practice nursing students, psychiatry, and neurology residents. And I would like to say that I met Dr. Weinreb at the liver meeting this year, and we were sitting side by side as Jen was on stage doing one of the panels. And I looked at him and I said, yeah, I'm a patient. And he was like, yeah, I'm a doctor. And I was like, yeah, I drank 3 bottles of wine a day. And he goes, oh, that's a lot. And then there we go, Bob. Our friendship was solidified with that. So with that, I introduce to you Dr. Bob Weinreb.
Sorry, unmuted. Thank you so much, Beth. Really don't need to go through all that. It's like, it's too much. It's too much for me to listen to. It's also a lot of years. So welcome, everybody. This is my pleasure and my privilege to be here tonight. It was a real eye-opener for me to meet with Beth and Jen at that meeting. And that meeting was in November, I believe it was. And I think it was in Boston, right? And I think the purpose of the meeting was really to kind of reach out to family members and patients who have been going through the process that you guys are facing, and for us to be able to talk about our role in that and to provide some guidance as well as be available for questions. And so I got to hear some great stories, and I found that this was a really wonderful experience. We kind of thought that we'd have about, 20 or 30 people. And I think we ended up with an overflow room of 300, which says a lot about Beth and Jen, I think. Anyway, I'm going to talk to you today about a book chapter that I wrote a lot of years ago with one of my fellows, Dr. Omer Abbasi, who is in private practice in Florida, doing the stuff that I'm the fellowship director for, which is consultation liaison psychiatry, which is really the very sort of poorly worded title of a field that deals with complex medical illness in general hospitals. I got involved in that through my work in liver transplantation and I got into liver transplantation through my work in addictions. So as Beth said, I did an addictions fellowship at Penn and the VA from 91 to 93 after finishing my psychiatry residency. And I went to that fellowship to learn pretty much, how to be a clinician scientist and how to write grants, and how to understand research and science a lot better than, I had as a resident, where we were just seeing patients all the time. And part of that process was to write a grant. And in order to remain there on faculty, you could do that and see patients, which is fine. But like I said, I came there to learn how to write a grant. And I wasn't really sure what to write. By the middle of my second year, I wasn't quite clear what study I was going to kind of get involved with or get into. And then a curious thing happened. One of my best friends called me up. I grew up in Buffalo, New York. So he called me from Buffalo and he said, "Hey, my dad needs a liver transplant." And I was like, "Whoa, what's going on?" And his dad was also my high school teacher, which is what my friend became also. So his dad really had developed a pretty severe alcohol use disorder and alcohol-associated liver disease. And this was back in the 90s. And so what my friend was asking me was whether or not it was a good idea for him to get a liver transplant. And I said, "I don't know anything about that. No idea. But let me go see what I can figure out." So I went to the library, because that's what we did in those days. We didn't use computers for that very much, not yet anyway. They were really impossible to use well, but the library was great. So went there and I looked up stuff. And then just coincidentally, the program director for my fellowship got a letter from the liver transplant service at Penn saying, "Hey, we're starting to see a lot more people with alcohol use disorder who need liver transplants. Is anybody in your addiction unit interested in helping us?" Well, I wasn't going to turn that down, because this was my chance to kind of get in there and with my boots on the ground, so to speak. And I took all their alcohol patients and to get to know them and work with them. And that was a total of 4, I might add. But I also, really got interested in what it was they were facing. And so I spent a lot of time talking to other people about what it was they went through. I talked to the surgeons. I talked to the hepatologists. I talked to the social workers. I talked to the nurse coordinators. I went out on organ procurement procedures. I watched them do transplants. I stayed up all night with them. I kind of just joined their sort of life and their lifestyle. And when I thought back to, what I had been looking at in terms of literature back in the library, I realized, okay, alcohol is the #1 reason for liver transplant in the country. At that time it was, and then hepatitis C kind of took over, and now it's back to alcohol again. And there wasn't one paper in the literature about the treatment or even the recognition of the alcohol use disorder. It was all surgical. And yeah, the surgery results were good, very good. But we didn't know anything about what to do with the actual problem that led people to get to it. And I thought, okay, now that is a grant worth writing. And so I did. And I wrote the first grant really in the NIH to look at how to provide support and treatment for people who got liver transplants for alcohol use disorders. And that's kind of how I got started in all of this. And then it kind of just took off from there. One of the things that I noticed early on in my work with people was that they were kind of different in some ways than the people who had alcohol use disorders that did not have liver disease. Most of them had quit drinking on their own. They did not have treatment. They didn't have AA that they were going to. They just quit, and they felt like, okay, I got this. I'm not going to go back to drinking. Who, after all I've been through, would go back to drinking? That would be ridiculous. And so I don't need help, and I think I'm fine. And I thought to myself, that doesn't sound logical. It doesn't sound realistic. And over time, we found out it was not, actually. We learned that even though there was a paper written coming out of Pittsburgh by the guy who invented liver transplantation, Tom Startzel, that said that liver transplantation is the ultimate cure for alcoholism, because only one of his patients went back to drinking, and they were very carefully selected. It was a different world back then. And over time, we started to see more and more people get in trouble and fall back to drinking after their liver transplant, as far as 5 years after. And so I've kind of geared my career toward the treatment of this disorder in order for people to hopefully get sober, stay healthy, and get a new life again. Anyway, this is a very long and drawn out explanation for why I'm sitting here. But the chapter that I wrote was based on some of the other experiences that I had and meeting, hundreds of patients a year who needed liver transplants for alcohol use disorders, and now doing this for about 30 years. I wrote this chapter with my fellow based on a bunch of what I thought were misunderstandings or myths that patients came to transplant with. So these are all people who had alcohol use disorders, all people who developed end-stage liver disease or cirrhosis from this. But I was always addressing it seemed to me I was always addressing similar questions from them and trying to help them understand misunderstandings that they had. So we wrote this chapter. And, I did it because I wrote it really for the doctors and the nurses and all the other non-psychiatric professionals in the field so that they would understand the patient's perspective. And that's actually the second page is called The Patient's Perspective. And it talks about the role of psychiatry in the field of liver transplantation. By now, I imagine most of you, if not all of you, have met somebody in the mental health world that is familiar with this field, and hopefully that was a good experience. So a little bit about my thoughts on that, and would love to get your thoughts on that as well, because maybe there's another chapter, that needs to be written after this. So myth number one is, you're the last one I have to see to pass the test so I can get my liver. And that is a quote from many, many people. And really, I think it was kind of a misconception that the psychiatrist was like the Roman emperor, like we were going to thumb up, thumb down, whether or not they survive, whether or not they get a liver. And I learned very early on that that's a terrible way to start a relationship with anybody, patient and doctor, especially in the field of psychiatry. And I wanted to give them an opportunity to be open and honest with me and not feel like that was going to count against them, that somehow this was going to interfere, in fact, with their getting a liver transplant. Make no mistake, if they are still drinking and they don't want to get help for drinking, and they just want to keep drinking, and then we can't really help them, that's a very different story. But that was very rare, if at all. The majority of people, as I said, were proud of the fact that they quit drinking on their own. And I was proud of them too. I don't think that's an easy thing to do. And I think they were confident about going forward and staying sober for the rest of their lives. And I think they were sincere. The problem is that life threw them some curves, and alcohol use disorders are tricky. And so if they didn't have proper support, treatment, and understanding of the disorder, they were, I think, vulnerable and putting themselves at risk again. And so those were the kinds of conversations we were having. And what I wanted to make them understand, or help them understand, is that my role on the team, as well as other mental health professionals, is to hear what the challenges they bring to this situation are, but also the strengths, and see whether or not we can develop a treatment plan to address those challenges, to make them a strong candidate for a transplant and stay as healthy and safe as they can be. And so I also explained that we are one voice on the team. There's a big team. There's sometimes as many as 35, 40 people sitting around the table talking about you guys and how to help you. And I can tell you from going to these things every week for 30 years, respect is the order of the day. The the program, at least that I work in, and I think most of them, really do see the suffering that people go through, and that is respected, and we do all we can to help. We really do. We're pretty flexible, actually. And so we say to them, again, I'm not here to stop you from this process. I'm here to actually help kind of pave the way. But there's a few things they do need to understand that's different about this psychiatric evaluation that we're sitting down to do, first time I meet them usually, than would be in any other psychiatric eval. And that's that what we talk about is shared with the team. So it's not a typical confidential evaluation. And sometimes when I'm teaching residents and students, I'll tell them that that's really an important first thing to talk about and let people know, because if they don't know that, then they're kind of coming into this, I think, under false pretense and feeling as though they can say things maybe that would be a problem if they said, and with the rest of the team. And I don't want anyone to also feel like they have to get themselves in trouble by telling the truth. But, there are ways of talking about these things together that we can create these plans of care so that people can be honest, actually. So we share everything with the team, but then we share everything with them too. So there's no surprises with what's going on. And again, the idea is that we are part of your team. We're on the same side as you are. So that was the issue with myth number one, that we were in fact the people that they had to pass to get, we had to pass them. Like this was a test. In a way, it little sort of kind of was, but it was a test that it was open book and that we all study together. All right. Myth number two is I feel badly that someone died so that I could live. This is a very deeply personal thing for everybody in their own way. And one thing that I think some people misunderstood is that that patient who would have passed away anyway. They were going to die no matter what. The difference is that they and their family had made a decision to provide the gift of life to others. And having worked with family members of donors, I found that they were really grateful and relieved that their loved ones didn't die in vain, and that their organs were going to people who could carry on and hopefully live healthy lives. And so I tried to tell people, guilt is an emotion that makes sense if you do something wrong, but you didn't do anything wrong by being a patient and getting a liver transplant from another person who did pass away. As I said, they would have done that anyway. But that's not an issue of guilt because you didn't do anything wrong. But maybe it's an issue of remorse, which makes some sense. It's a very sad thing. It's terrible to think about what that family had to go through and what that individual even had to go through. And so we talk about the fact that there's comfort that this brings to the families of donors. And so that person who made the decision to do this, their wishes were honored at that time. All right. Myth number three. There are so many others who deserve a liver more than I do. And besides, I'm probably not going to get one anyway. So I don't know what this sounds like to you guys, but to me, it sounds like I give up and I don't want to try. Or maybe I shouldn't try, or I don't deserve to try. I think that's really a big part of it. And actually, I think it's very common for patients with addictions of all sorts to feel a bit less worthy than their non-addicted counterparts in life. And I think they feel as though people who didn't, quote, bring this on themselves, and again, that's not my belief, but that's the belief of a lot of people in society and even the patients themselves, so that they're going to be less worthy of getting this liver, this transplant. And what we're talking about is the very normal experience of feeling guilty again and ashamed of being in this position. It's a very difficult position to be in. Here you are in front of all these professionals white coats, doctors and nurses, you can really understand how easy it would be for them to judge you, to criticize you. And hopefully that doesn't happen. But I believe that people are extremely sensitive to that. And that makes sense to me too. I know I would be. And so what we try to explain to them is that, they do deserve a chance at life. Everybody deserves one. And that ambivalence, those mixed feelings that they have about whether they do and don't deserve to live and do and don't deserve a liver are really related to the type of feeling less than that a lot of people feel as they go through early recovery. And then when they finally forgive themselves, I think they hit a new plane and they do better. And they don't let that negative energy get in the way of things because that doesn't really help anybody and it's just not accurate. And so this is also another reason I think people can get into counseling and therapy is to talk about this guilt and this shame with a professional who is hopefully objective, non-judgmental, and doesn't criticize, and helps you to do the same thing for yourself. So there are a few more myths, but I wonder, Jen, if this is a good time to stop, because I don't want to read like 8 myths and then have people forget what they were going to talk about or ask questions about.
I think that would be great. Maybe just to pause and see if anyone has any questions right here. I know that those myths, I've heard those in other groups that I'm in too, and and the shame that people experience. And I know the one thing about this group is we want to counter that shame with empathy, and because we know that that empathy is what is going to help us understand that we are deserving, and we are deserving of the life that we've been given. And so if anybody has any questions for Dr. Weinreb at this point, please ask. Or if this has been a myth that you've experienced yourself or went through and you want to share a little bit, please, you're welcome to share. And please raise your hand if you can with the raise your hand button so we can see you.
I'm going to go ahead and jump in here real quick.
Let's go to
Paula.
Yeah.
Paula, go ahead with your question.
I'm not sure if, Doctor, I'm not sure if you can answer this or if it's for somebody else, but my question is about immunizations. Is that the right question to ask you?
It might be, but I'm not quite sure it pertains exactly to what we're talking about here today now.
Okay. I'll save it. I'll save the question. Thank you.
Yeah, we have one of the hepatologists here who's an observer who may have some time to address that question. It's definitely a good question.
Okay, it's about live immunizations. That's my question. It's regarding the live immunizations that I'm pursuing right now to volunteer at Sutter Hospital in Sacramento. I'm in Sacramento. I want to give back to them. So that's pertaining to my question. So I can wait and ask the other doctor.
Okay. Thanks, Paula. Thank you for your question, though. We appreciate you interacting with us.
Thank you.
Anyone else? Go ahead, Beth.
I want to just jump in here and give Dr. Weinreb a chance to have another sip of water or something. But I heard something this past week. I just came from the transplant games in Birmingham, Alabama, and we got into this discussion about objectivity on a medical professional standpoint. And I found this one doctor's comment very, very poignant. And he said, as medical professionals, we transplant organs, not morals. And I thought that was something for us to really think about and take back with us, because I thought that was very good. And then the second thing to point out, piggybacking on what Dr. Weinreb said about our donor families, is that I got the chance to see so many donor families at these games and watching the recipients compete and things like that. And like he said, they really were so appreciative. And whether they knew their recipient or not, you were that person for them. So I've struggled with this in the past. Somebody had to die for me to live, but then they were watching me. I didn't compete, but they were watching other people compete and thinking about, hey, that could be my son, daughter, friends, whatever organ there. So the gratitude that they have is really, really for real. And if you get the chance to talk to a donor family, definitely do that. So I just wanted to make those comments in there and give. So back to you, Bob.
Thanks, Beth. Yeah, and just adding on to that, one of the things I also talk to patients a lot about is writing a letter to the family of the donor. And that's a really difficult thing to do. How do you even start that kind of letter? Like, how do you begin? And the answer is you just do. You just begin. And you don't let what's, great be the enemy of the good, if you've ever heard that expression. It's not going to be the perfect letter. That's okay. I think the point is that if you want to communicate with those folks, you should give it a try and say what's in your heart. And these things are reviewed by the procurement organizations, the groups that do all of the administration and organization of where the organs go to when they need to. And they look at them carefully to make sure that what you're saying in there is going to be acceptable to both parties. Not that you would say something wrong, but they don't want you to sort of give any information that can identify who you are unless you want that to happen and they want that to happen. And so there are, articles and books written about, how to write these letters and whatever. I usually tell people it takes a while. Like, I wouldn't do it like in the first month when you're all hopped up on steroids. It's God knows what you're thinking, what you're writing. And it probably will be very different 6 months from then, when you're feeling hopefully physically better and the doses of all these medicines are lower and you feel the way you hope to feel, and starting at the beginning.
Hey, Bob, I wanted to interrupt real quick because I know some people on this call have had their transplants maybe for a while. Could I get if you don't mind, a show of hands of anyone that has actually written one of these letters?
Mm-hmm.
All right. Yeah. Wonderful. That's great. But it's still. Go ahead.
Hey, Jen, I just wanted to point out that most transplant centers will not let you write a letter until you are at least 6 months post-transplant, probably due to what Dr. Weinreb just said, that you don't want to be hyped up on steroids to do that. But I'll go ahead and take Hannah's question. What you got, Hannah?
Oh, I'm a year and 2.5 months out from my operation, and I just went off prednisone like last week, so no steroids, I don't think. But I want to write my letter. But the thing I'm nervous about is saying I'm an alcoholic. Do I necessarily have to say that? Because I don't want them to think, oh God, our liver went to someone who might ruin it. I just didn't know what to say about that, or do I say anything?
Can I say something here? I don't think the procurement organization will let that letter go if you say that. I don't think you can give
Okay.
for your liver disease or transplant. You can't talk about anything religious, no religion, no personal information at all, except for maybe, I think, your first name and your age and sex. And you can tell them, like, I have kids and stuff, but
Okay.
I think you're allowed to tell your reason for your transplant or where you were transplanted.
Okay.
You're not allowed to name the center. You're not allowed to name the geographic region. And usually the rules are that the recipient and the donor family correspond twice. Each one writes a letter. And then if they would like to meet in person, that meeting is facilitated by the organ procurement organization after those 2 letters have been written. If you go online, and I rarely say Google anything, but if you do Google how to write an organ donor letter, there are some really, really good examples out there. And Jen, maybe this is something we can talk about more in the reflections part after the meeting, if people want to know a little bit more about. I know I've written one, and several people on here have.
That would be good. That would be good. Yeah.
Great. Because
After that, now I think they would be happy that a recipient of their loved one's organ and that you're living a good life now.
Mhm.
If it were me, I would not be afraid to tell them what caused my liver disease if we were to start that open line of communication.
Okay, thanks.
That's-
That makes me feel
It
better.
will- I think they would be glad that I'm here and I'm honoring their loved one best I can and giving him the life that he didn't get to live.
Thanks.
Good.
Thanks, Nancy. Thanks, Hannah. I definitely think this is a good reflections topic. So, and Bob, if we said anything or Dr. Singal incorrect, if you could to let us know. But these are some pretty knowledgeable folks. This is something I don't have as much knowledge on since I'm on the not needing the transplant yet side.
No, I want to say, thanks for, this is Ashwani Singhal. So thanks for inviting me because really, happen to be your witness this kind of meeting where not only you're learning from an expert like Dr. Weinreb, but also from perspectives from, I could use the term patient advocate and patients. So I think that's a great group, like the one right now I'm talking to or I'm listening to, because those are the things I always believe in, that books can teach you something, but what patients can teach you, nobody can teach that. So thank you for having me here. Yeah.
Thanks, Dr. Singal. Really appreciate that.
Yeah.
All right, Bob, back to you.
All right, next myth. Maybe I shouldn't call
Yes.
them myths. They're really not myths. They're misunderstanding. The next one is let's go here. Number 4. Right. You're saying I'm an alcoholic, but I'll bet you think that because you never took a drink in your life. Yep, I've had that conversation too. And I think if you were one of my residents or my students, I'd say, what's going on here? What do you think is going on in the mind of that person for them to say this to me? How are they feeling? What's going on? And I think it goes back to whether or not they're afraid that they may not be accepted by you as a physician. Not accepted like, yes, you can have a liver. I mean, accepted as an individual. The whole moral issue comes up again. Are you judging me? Are you criticizing me? And the answer is that they may be doing that and projecting it onto me as though I'm feeling that way about them because they're afraid that I'm feeling that way about them. And they're afraid that they feel that way about them. And they don't quite know how to handle that. And that's not abnormal. That is normal. That's a normal feeling. It's a normal concern. And what I say to them is, I was very lucky. I was not born with addiction in me directly. It does exist in my family, so I've seen it from that perspective. And I understand it as best as you can tell me. And so this really underlies the significance and the importance of you're helping me understand what you go through, because you're different than anyone else I talk to who's going through the same thing. And so even though I may not have experienced what you have, I might still have something to offer you and help you if you help me understand you. And so we form a team. And it's not too different than the doctor who is treating cancer patients and has never had cancer, but they can still do a really good job of treating their patients. And so that's a bit how I feel. But without you as a patient's kind of buy-in, if you will, without your contributions to my understanding of you, it doesn't work as well. And so hopefully that partnership is made clear. And this is an opportunity when that question is raised by an individual to address that, hopefully in a way that makes them feel safe and comfortable and learn to feel a little less critical of themselves for why they're there. So let's see. Myth number 5 is I'm depressed, but I have to live with it because my doctors told me I can't take any medicine for depression. It's not good for my liver. That sound familiar? Anybody? You probably get lots of differing opinions from lots of different doctors. A lot of doctors in the community who don't work directly in transplant do feel that way. They worry that the medicines that they are giving people are harmful. In reality, very few of psychiatric medications are harmful to the liver. If you think about your liver as like a furnace, and when you're sick and your liver isn't working at full speed, your furnace is still working, it's just not working efficiently. And so it's not getting rid of the gunk in the furnace that it needs to at a normal pace. And so if we put medicine into the furnace, what's going to happen is it's just going to take longer for the furnace to break down that medicine and distribute it to the body. And so we start with very low doses and we go very slowly. And then that tends to be pretty good outcome for people. But there really is nothing to be afraid of with regards to these medicines. There are doctors who work in transplant who make it their business to make sure which ones are safer than others. And the ones that aren't safe, we just don't use. We don't try to use them. There's no point in doing that. There are plenty of other alternatives. And so, people who do have depression, people who do have anxiety, who have treatable disorders, bipolar disorder, schizophrenia, whatever psychiatric illness you come in with, it's our job to do a really good job of making sure that diagnosis is accurate for you and for us to find the best treatment we can give you. And we really like it when you ask us questions like, is this going to hurt my liver? What are the side effects? What can I expect from this? How long will it take to work? How do I know if it doesn't work? When do I call you if it's a problem? Those are the kind of conversations we like to have. Call us out on those things. I mean, if we're not telling you the answer to those questions, you deserve to have the answer to those questions. So push us. If we're busy, we'll sit down. So what? Our job is to help you understand this. The more you know about whatever it is you're putting in your body, the more likely you are to get a benefit out of it and to use it appropriately. And if it doesn't work, like today, I had a patient who I was talking to about starting, a new medicine for depression. And I said to her, if after a couple of days of taking this, you really don't feel good, just stop it, but call me and tell me. You don't have to take it. You don't have to suck it up and hurt yourself doing this. Really, there are so many options, but the earlier you tell me about a problem you're having, the better it is for both of us that we can kind of address this issue and possibly switch to something different or figure out what else is going on. So again, it all comes down to the partnership aspect of it and really, really being comfortable with asking your doctor all the kinds of questions you have. Now, I also know that a lot of times patients come into the doctor's office and they're really nervous or they feel a little bit intimidated. And so they may not ask the questions or may not even occur to them until much later. So write stuff down. And then, most of the hospitals have these, portals where you can write to your doctors and ask them questions. And so if you get questions later and you can use that portal, that's a good way to get through to them. And they won't maybe answer you immediately, but hopefully they will answer you. And sometimes what I do is I just pick up the phone because it's a lot easier than writing and it makes more sense. And you can hear more about how that person is thinking and feeling and address their issues. So don't be shy, I guess is what I'm saying about this. You have the right to understand what's going on with you. And to ask for that is not inappropriate. In fact, it's better for you. And I think most doctors like that, honestly. I think they feel like, yeah, educated consumer, perfect. That's what we want. All right, so that is the story with the liver and the medicines. I could go through side effects.
I want to just jump.
Yeah, please do.
Hey, Bob, I just want to jump in here real quick and say we've got about 10 minutes left in the standard call. So I don't know if we want to kind of stop it there and let folks ask some other questions? Because it's obvious we're going to need you back for an encore because everybody is really enjoying this conversation. But I do want to just let people know, our end time is 8 o'clock. So how do you want would you like for us just to take some questions and we can pass them on to you?
Yeah, that'd be great. Let's do that. I've heard enough of myself at this point.
Did you want to
No,
wrap up
never.
anything, Bob? But yeah, because we would love to have you back. And then if we have a couple of minutes, we can ask if anyone has any questions real quick, and then we'll we have a couple of housekeeping items to go over right before we end our meeting. So but yeah, do you have anything that you'd like to wrap up with? I don't want to just cut you off without your beautiful ending.
No, I mean, there's just like one more myth, which is I kind of raised it in the beginning, so we'll let it go. One of the things I tell my patients is that once you're our patient, you're always our patient. And that means that we have to get along. And even if it's a dysfunctional family that you're adopting, we can work it out. And I just want you guys to know that that's how we feel, and that's why people who go into transplant, the surgeons, the hepatologists, the pulmonologists, all those specialists go into transplant because they like to see their patients across their lifespan. They want to work with you. They want to get to know you. It's different than a general surgeon who's going to take out your appendix and wish you well. That's fine. That's great. But that's not why we went into this. So I just want to mention that.
Johnson, looks like you got a question.
Sorry, hopefully that's for
There
me.
you
Okay, yeah, I'm sorry. Thank you so much for coming and talking with us this evening, Dr. Weinreb. I really appreciate it. It's great information, and hopefully I'm not belaboring anything and stretching out this conversation too long. But I thought it was really interesting at the beginning when you were speaking to the attitude of a lot of the patients that you had spoken with who had kind of a very strong, resolute kind of desire to stop drinking and not believe that that was going to be a challenge for them. But yet we're faced with unforeseen circumstances that may have brought them back to that in the future. Anything you can speak more to about what gave them skills for having more resilience to some of those challenges, or anything else that maybe are of interest to us here in this group? And again, thank you very much for talking to us.
Oh, you're welcome, and thanks for that question. It's a great question. There's a reason why there are, as many billion people on the earth as there are, and that's so we're not alone. We should not be alone. We learned that through COVID. That was a killer. I mean, literally caused so many problems. It's a whole nother show. But the point is that people sometimes become isolative and alone when they slip or when they have a relapse. And they either don't tell people or they hide it. And the truth is that a lot of people, especially family members, know anyway. They can tell just by looking at you that something's wrong. And my experience with that is the sooner that you come out and talk to others and ask for help, the better you'll be for it. And you come back into the hospital, you've had your transplant. We're not going to ask you to give us your liver back. I promise you get to keep it. But but we will talk about what happened and see whether or not we can come up with the next better steps to improve that resilience. But what I think a couple things that lean people back, one of them is boredom. That's a big one. If we take something away from you, like drinking, we have to put something back, because if you don't have another thing to do that makes you feel good about you and it makes you feel like you're not alone, something different that gives you joy, then it's going to be very difficult for you. And so that's one thing, boredom. And the other thing is that feeling of like, okay, one won't hurt. I've been sober for 2.5, 3, 4 years now. Things are different. It's going to be okay. I think I can handle this. And what I say to them is that we really don't see controlled drinking as a successful option for anybody. But there are medicines that we can give you that can help you with cravings and urges. And if you do have a slip, it will stop you in your tracks and keep you from going over the edge. And so all of those things are available to you. And we're happy to talk more about that, anytime. So there are lots of options that we have, but the idea is really that we work together on this, and that even if something happens that was unexpected and not healthy, don't let that be the end of the story. Let that be the beginning of a different story. Come in and talk with us.
Thank you so much, Bob. I really, really appreciate you. Dr. Weinreb he's just become I feel like he's become a really good friend of mine just in the time that we've known each other, because we've chatted about so many different things, and I really appreciate his outlook and how much he really how much he cares about what's going on with us, the patient. So thank you so much for coming, and we will write down all the questions that we have for you, and Beth and I will spend another couple hours with you talking about questions, and maybe we could do another interview just about the questions that we get from our folks. So thanks so much. I really appreciate it. And but for everybody else, and Bob, if you want to hang on here for a few more minutes, I want to thank everybody for listening and for being a part of this. We are going to have our reflections period after this. And Jason, did you have something you wanted to add? I don't want to cut you out here.
I apologize. That was a misfire.
Oh, okay, no problem. No problem. So quickly, with the last couple of minutes we have left, Erin, thank you, Erin. Erin is one of our advisors. I want to thank our advisors, Erin and Nancy and Lindsay and Jack, for helping us. And of course, Beth, our principal strategic advisor. And a couple things for you. Next month, we're going to have an open discussion meeting so we can all talk and chat all we want about what's going on in our lives and what we need help with from others. And we are also developing a new website, and our website launch will probably be within this next month. So as soon as we do that, we will send a message out to all of y'all and let you know. This also includes a new communications platform, which I hope is going to be extremely successful, getting everybody's messages to where they need to go and to everyone. So thank you all for being patient as we work through our little growing pains as we are growing as an organization. And we want to thank everybody for helping us grow this organization. And lastly, we are going to be moving off Zoom onto a new platform. The name of the company is called Hey Peers. We're going to spend some more time on this next month because we're going to be implementing it to start our September meeting on this platform. It's going to be a more secure platform. We won't have to worry about anybody bombing our meetings, as many times has happened in a lot of liver meetings and other meetings lately, especially in the summertime. And it's also going to be a place where you can also look for other meetings that you may be interested in joining. And it's also going to be a way for people to find us. Beth, did you want to add anything about Hey Peers?
What I will probably do for those that are interested is I'll probably record a how-to session once we get in there and put it on the website. You will have to re-enter you'll have to submit your email one more time, but you will just be creating your own password. So from now on, instead of just clicking a Zoom link, you will enter in your own credentials to get into a site to have the meeting. So it will be a lot more secure, and I'll make sure that you guys know how to do that and how to get on it. It should be very exciting.
Good. Yeah. And lastly, I just wanted to say, please share with all of your friends about Sober Livers, and because we would love to just keep on building this community. And this community is for you, created by you. So if you have any suggestions or recommendations, please join our Facebook group and start a conversation there. And if you don't have Facebook, please shoot us an email. My email is directly right there on the website, and you can get in touch with me, and I'll make sure that we get all your questions answered. But we do have our reflections period after this, which will be for 30 minutes, and it's going to be open discussion, and I'm going to stop the recording so no one has to worry about any of their secrets getting out. So with that said, thanks everybody for coming. I appreciate you, and we hope that you will stay after if you would like. And thank you, Dr. Singhal. Please, thank you. Come again if you'd like to. And thank you, Dr. Weinreb. We appreciate you. And we are so thrilled that we have you dedicated to our liver disease, because we need people out there like you fighting for us every day. Thank you so much.
Thank you.
Thank you all for viewing this video. We really appreciate it. The next portion of our meeting is called our reflections period. We do not record this. This is when we carry discussions that we had in our meeting into open discussion. Like today, we discussed writing letters to your donor family, and also continued on some myths, such as, do you get traits from your organ donor because you have their liver? It was actually a lot of fun. And so we hope that you can join us at our next meeting, which is going to be on Tuesday, August 13th at 7 p.m. For anyone that has liver disease or has a transplant due to alcohol or loves someone who does, please join us. You can do that by going to soberlivers.org. Again, that's soberlivers.org. And we hope to see you there. Until then, Amora Fati.